So my name is Jennifer Gillick, and I am the program director here at the Northwest chapter of APDA. So thank you for joining us for this Take Control program. Today's program is Gender Matters. It is a discussion of gender differences in Parkinson's disease. Shannon, our moderator, will be introducing the topic a little bit more to you, but I want to tell you that I've become more and more aware of this, and this is a topic of greater research in the realm of Parkinson's, how gender influences Parkinson's disease. So we're going to talk about that today. So we have a great panel of folks, so I think this is going to be a terrific panel. What you need to know, this program is going to be about an hour long. It will include time for Q&A. There is a button next to the chat that says Q&A, and that is where you can pose your questions at any time during the program. We are recording this program and it will be archived on our YouTube channel. I will send a link to that out with the post-event email, but you will be able to share that or watch it later if you want to go back to it. And like I said before, you can use the Q&A for a chat. So I want to thank today's sponsors. This is how we can do the work that we do, present these programs. So Kyowa Kirin and Boston Scientific are both some of our corporate sponsors who have sponsored this program because they really value education for folks with Parkinson's disease and those who are impacted. So thank you for their support very, very much. So just a little bit about APDA. You're here because maybe you know a little bit about what we do. We are here as an organization. The Northwest chapter is here in our Northwest community, but all across the country to provide support, education, and research that will help everyone impacted by Parkinson's disease live life to their fullest. So we really focus on 5 key areas. We keep people moving through our online exercise classes, as well as linking them to community programs. We keep people connected through support groups and programs like that. We keep people educated through things like this. We provide financial support to folks with Parkinson's through our Patient Aid Scholarship Program, and we fund critical research. So you can learn more about us on our website. All of you went there in order to register for this program. But we provide a lot of services, and the way we do that is through individual donations and corporate support. So all the donations that are made to our organization really make an impact in allowing us to do our work. And that includes people who donated when they registered for this program. So thank you for that. And before we begin, I just want to let you know about an amazing, very special 20th anniversary event coming up on March 11th, just in a few weeks. I was in the office madly photographing all these fantastic auction items. This is the 20th anniversary of our Magic of Hope Gala. It is an online auction and party. It is quite actually fun and interactive, which I was very surprised by last year. You can join us from anywhere, wherever you live, and it is free to attend. And it's going to raise money for our organization. So come spend an evening on March 11th with us. You can bid on auction items, or you can just be part of celebrating this Parkinson's community. So we really invite you to join us, and I will send information out about that in our post-event email. So enough about us and APDA. You are all here for this Gender Matters discussion. So I am going to welcome to the screen our distinguished panel of participants. So welcome Shannon, welcome Larry, welcome Kat, Maria is popping on, and Michael. So thank you, all 5 of you, for taking time out of your day and being part of this discussion. I am now going to disappear and turn it over to Shannon, who is a physician assistant at OHSU, Oregon Health Sciences University, and she is going to introduce this topic and our panel. So thank you very much, and I'll see you in a bit.
Thank you, Jen. That was a fantastic run up to this really important topic. I'm super excited to be speaking with all of you and to have an opportunity to really tackle some of these issues. When we had put this idea together. Really, the goal of this entire session is to encourage all of you to think about how sex and gender may impact Parkinson's disease, and hopefully inspire some of you to start asking some more questions either within this session via the chat and the Q&A box, or hopefully kind of start that conversation outside in your own communities. So just to give a little bit of an introduction, we all know anyone who's acquainted with Parkinson's disease or the Parkinson's community is very familiar with the phrase, if you've met one person with Parkinson's, you've met one person with Parkinson's disease. And although I don't know who specifically said this first, I do know that this phrase really reverberates throughout our exam rooms, our support groups, and our Parkinson's community. So in some ways, this new trend that medicine is sort of getting on board with of personalized or individualized medicine has been something that has been within the Parkinson's community for quite some time. So we've really been kind of ahead of the curve in that way. However, when it comes to how sex and gender might influence this conversation, this is where we're really behind the times. We all sort of think of, when we think of Parkinson's disease, sort of this older white male is what kind of pops up, and it was sort of what is perpetuated in our medical training and perhaps in our communities when we sort of think of who typically gets Parkinson's disease. And more importantly, really, there's not a lot of research on how to inform our patient populations or practicing providers on how to incorporate one's sex or gender identity into routine care. So for these reasons, the APDA has assembled this panel today so we can have an open conversation about this. So before I introduce the panel a little bit more, I do want to define a few terms right up front. So sex refers to our different biological or physiological characteristics. So things like our reproductive organs, chromosomes, hormones, those types of things. Gender, by contrast, is one's innermost concept of self. This can be as male, this can be female, this can be a blend, this can be neither. And so one's gender identity may or may not be in alignment with one's sex, but both sex and gender independently influence one's experience with the symptoms of Parkinson's, the response to the treatments, and also have a pretty significant psychosocial impact on how you define quality of life and how you look for the best possible care. So each of our panelists are going to speak on their own specific experiences, and as we all do, we hope that this will inspire you to think about how this impacts your own experience. So first up, Dr. Maria De Leon. She is a neurologist and fellowship trained movement disorder specialist in Texas. She's instrumental in developing the Women in PD initiative. She authored the first ever book addressing women's issues in PD titled Parkinson's Diva, A Woman's Guide to Parkinson's Disease. And more recently, she's written her second book available in Spanish called Living Beyond Parkinson's. Maria was diagnosed with PD about 15 years ago. And in addition to her efforts in the clinic, she is a very active voice for advocacy in the PD community. So welcome, Maria.
Thank you so much.
Yeah. Larry Gifford, also here, is the president and co-founder of PD Avengers, which is a global alliance united to the cause of ending Parkinson's. Larry was diagnosed in 2017 and continues to work full-time in radio. And together with his wife, Rebecca, Larry hosts a podcast, When Life Gives You Parkinson's, where you take on an honest and hilarious, engaging ride through the journey of having Parkinson's. So I highly recommend it. Larry's also wearing pink. Do you want to say why you're wearing pink today?
Sure, yeah. I'm in Canada, and so today in Canada, it's Pink Shirt Day, which is anti-bullying day across the country. So we just bring a light to anti-bullying.
Awesome.
All the kids at school are wearing pink today. It's really cool.
That's amazing, and I definitely want to bring that stateside. So if we can reach out to the people on this call too to help bring that here. I love this idea. Next, I want to introduce Kat Hill. Kat is the co-founder of the Women's Parkinson's Project. Kat was diagnosed in 2015 and is a retired nurse practitioner and nurse midwife. She has answered the call also to advocacy for women's issues in PD, and her first book, Being Well, A Guide to Finding Joy and Resilience with Chronic Illness, will be available this summer. So we're very excited to check that out. And Michael Franich, who is a retired teacher and was diagnosed with PD in 2018. Michael's based in Milton, Washington, and is very active with the Pacific Northwest chapter of the APDA. In particular, he assists with outreach and support to those who are newly diagnosed with Parkinson's. And having had cared for two parents with chronic disease, really understands the importance of assembling a successful team and being your own best advocate. So without further ado, Larry, I think I'm going to come to you with my first question. So
Okay.
as we have met, I've heard from each of you in one way, shape, or form that I have PD, PD does not have me. And that's such an inspirational attitude, but I'm curious, I mean, there are so many symptoms that come on with Parkinson's disease, the motor symptoms, the non-motor symptoms. And so I was hoping you might be able to speak to a time when maybe that having the symptoms of Parkinson's challenged you to maybe redefine how you view yourself, perhaps in the context of as a spouse, a husband, or a father. How might that have been for you?
Every day. But I think that the key for me has been understanding that it's not going away. And so it's like my shadow. And so no matter how I feel about it, it's not going to affect it being in my life. And so I might as well embrace it and leverage it to my advantage as much as I possibly can. So I can live a better life. And so it doesn't need to be about everything I do. I still have a full career, and I still have, my 12-year-old son, and my wife and I have been married for 23 years. But like my wife and I, we have to communicate differently now because we're both communicators by trade. I'm on the radio. She's been a writer all her life. And we just sort of had this groove, after 20 years, you kind of read each other's mind and finish each other's sentences. Well, I'm reading her mind and I don't understand it anymore. And so I take things a lot more literal than we used to. So like subtleties escape me. Or she'll say, she'll give me directions, but she'll only give me half the directions. And so I'm like, well, I did what you said. She goes, well, can't you fill in the blanks? And it's like, no, I can't anymore. And so we've really had to sit down and have some really honest conversations about, just how Parkinson's is affecting the way we communicate. And then at work, I have to negotiate, what can I do? Like, what am I able to do to contribute to the office on an ongoing basis? And that's changed year after year after year. And they're working with me so I can continue to work, but only have to do the things that I'm capable of doing.
Thank you for that. You bring up some really nice points in terms of communication and how that relationship dynamic, not just your own personal identity, but your identity within that relationship, is challenged at times by that diagnosis. And so, Michael, I was wondering, maybe in your experience when you received the diagnosis of Parkinson's, did that challenge your relationship or the dynamic that you and your wife share with one another?
Yeah, that was particularly difficult, and it speaks to gender differences and the fact that I pretty much shut down. I'd planned on retiring a month after I received the diagnosis, and it was like a complete reversal and change of plans. I was an outdoor guy. I've been around the Wonderland Trail twice. I kayaked in Alaska. And suddenly I was very uncertain about what the future held and what kind of changes I was going to have to make in my life. And fortunately, my wife got busy and started doing research. And pretty soon we found APDA, we found the Davis Finney workshops. I started getting information and making small changes in my life, which gave me the confidence to make bigger changes. I discovered gyms and changed my diet and pretty much turned things around so that I kind of look now at Parkinson's as a part-time job. It's not my life. I'm going to continue on doing the things that I really love to do as much as I can. And when I can't ride the 2-wheel bike anymore, we're going to 3 wheels.
I love it. That's excellent. One of the things you in particular have really been helpful with is identifying those types of resources or groups to kind of help build that community right out of the get-go. But what are some of the kind of simple suggestions that you might have for someone trying to find that community?
You have to take things one step at a time. I didn't understand the concept of what a team was until I did quite a bit of reading and worked with, starting with my family doctor, worked up to a neurologist. But in terms, that's the most important thing is having this support network so that when you have questions or issues, you can go and get something answered, and understanding that each person on the team has their own little bubble, their own little focus. And you can't expect them to connect all the dots. So I like to write. So one of the things I do at least once a year is I make a big summary of where I'm at and how all these other things I'm doing have helped, especially in terms of acupuncture. I see a counselor. I've got a pretty broad network of support services. I don't use them all the time, but if there's an issue, they're there for me and it keeps me going.
That's excellent advice. I really love that focus. Maria, maybe taking that to you as the neurologist, and oftentimes you're sort of the first person who gets added to someone's team, the one giving the diagnosis. I'm curious how sex and gender influence your care. When you walk into an exam room, do you take into account sex and gender kind of right from the get-go as you're performing your clinical interview or thinking about treatment options? How does that influence what you do?
Well, for a long time, we didn't really think that Parkinson's had gender differences. So when it came to my Parkinson's patients for a long time, I didn't really consider gender because most of them were, older. And so we're not in reproductive years and, they were not planning to have kids or anything like that. But certainly was something that I was very used to with my younger, migraine patients and myasthenia and seizure patients, always considering, their hormone status, their reproductive status, their social status. But interestingly, it's something that when I started seeing the first patient that was young with Parkinson, she was a woman and she had had it for 20 years and she started in her 20s. That kind of started, percolating things in my brain. Then the second patient came and again was pregnant and, what do we do? And it all came, barreling down when I suddenly developed, symptoms at my late 30s, mid 30s. I was a young mom, a young practitioner, a full life, practice, a toddler. So then all of a sudden it's like, okay, wait a minute, this my Parkinson's is not going to be the same I've approached all my other Parkinson's patients because, I'm still having, menstrual cycles, I'm newlywed, I'm starting a career as opposed to ending a career, I'm still thinking about having more kids. So those kind of things came into play. And then lo and behold, when I started taking treatment myself, started noticing that there were big changes with my menstrual cycle that were occurring, and my menstrual cycle was making my Parkinson's symptoms worse. Of course, having migraines my whole life, I was already aware of what the menstrual cycle and things like that, hormones place on migraines. So I started really thinking that, I think there's a lot more that we've been missing. Of course, dealing with Alzheimer's and things, we know that estrogen and heart disease in women and stroke in women. Again, I'm very familiar with all those things being a neurologist, that hormones play an integral part of those diseases and how we manage it. So that's how my research and my, women initiative and PD began, because of my knowledge as a physician dealing with all these women with various neurological issues, and started asking women across the country and the world, hey, do you notice symptoms, difference? And started seeing more women, and everybody's like, yeah, and so then it's like, okay, let's look into this. So now, of course, we look into women that when they come in, certainly gender plays a role, but 15 years ago, 20 years ago, that was not something I would have thought of for Parkinson's. So long story short, so yes. So I'm glad that we're having this discussion and that we're seeing this movement, because I really do think that even, other neurological diseases, other diseases, just because women and men are so different, and women don't participate as much in research. We don't have a lot of data that says, the medicines are going to work differently in men and women. We just take the doses, the strengths and whatever we have from most of the research that's done in men. So I think that now we're having this opportunity to have some input as to, is there really a difference? Does, not just hormones, but does gender and sex play a definite role in how we diagnose, treat, and deal with disease? And I think it does. But we're in the right. We still have a long ways to go. But making one little pebble at a time. One little in the pond. So.
Absolutely. I mean, you bring up such good points, and I can see a lot of those in my own particular practice. The trying to get that right dose and find that right treatment plan. And seeing some trends in my male patients versus my female patients. And Kat, I was wondering if maybe you could speak to some of your experience coming up with a treatment plan. I mean, the decision to start medications, trying to tailor it and get kind of the most out of each pill and the finding the right routine. Can you maybe speak to how that was for you?
Sure. So when I was first diagnosed, I was still having regular menstrual cycles also, but I was entering or about to enter perimenopause. And I was having trouble sifting out what was going on. So I had Parkinson's symptoms like so many of us for many years, but wrote it off as other things, especially around my cycles. I might have a little bit more of that twitchy feeling. And so I think that because there is menarche when we start our periods, perimenopause, and then menopause, that sometimes it's harder to sift out what's really going on with our bodies. And to add a neurologic challenge or some of those symptoms, even I as a clinician didn't have it on my radar at all. I thought what was going on was perimenopause and possibly some thyroid issues. So it was hard to sift out. I think it was, I was also in a fair amount of denial, like any good clinician. I'm sure that's not what's going on with me, even though my dad had Parkinson's. So for me, I had to first accept that Parkinson's was joining the party, and that took a little while. And then I had to tease out what I was ready to take on in terms of medicine and treating my symptoms. And could I manage my perimenopausal symptoms? Was that smarter to tackle first? Because frankly, hot flashes were really getting the big bill for a little while because they were so debilitating. I told a lot of people I was shaking and baking my way through my midlife. Because for one thing, it helps to laugh at it, right?
Yes.
And the shaking was certainly getting my attention, but it was the hot flashes that were starting that were really more debilitating initially. So I think it's just complex. And I think that having been a clinician and a nurse practitioner, I believe in kind of the holism approach, right? We're not just our neurology or our reproductive health or our orthopedic health or our gastrointestinal health. We're one whole package. And so, but it's complicated, and we have specialists because there's a lot to each area. So what I want to say to women out there, if they are experiencing symptoms, if they're cycling, if they're noticing it's different, we've got to start talking about it in the exam rooms. If it's not asked about, we've got to start sharing it. Are our symptoms worse the week before our period? And then, oh my gosh, my medicine worked so much better the week after. Would it help to have some treatments for some of those perimenopausal symptoms? So I may be jumping around on you, Shannon, but that would be my hope today, that women hear us. We are gaining some traction. Historically, it was scary to include women in research if they were of reproductive age, because what if they got pregnant? But we're learning ways that we can do that. So we've got to get involved. We've got to raise our voices. And I appreciate everyone coming out and listening to us today talking about this.
Kat and Maria, I just want to touch on what you just said because I think it's fascinating, and I don't want this to go by. But like 4 years ago at the World Parkinson Congress, the Parkinson's Foundation did a presentation on women in PD. It wasn't very highly attended. I was there. I loved it. I thought it was fantastic. And it was, there was some great data there that I'd never known. So I was talking about it with some folks, and Amatola Thomas was there. And she goes, "Oh yeah, levodopa doesn't work when I'm on my period." And I'm like,
Yeah.
"What?" Like I had no idea. And then somebody else goes, "Oh yeah, it doesn't work." I'm like, if a man had to take a medicine that didn't work 1 week of the month, we'd have 17 different ways to fix that.
Yeah.
But we weren't even aware this was, I wasn't aware this was an issue. And I'm sure, if that's not being discussed in the doctor's office and the neurology office, if they're not asking those questions, why would they need to address it?
Yeah, I have often said that I think we need to treat Parkinson's like we do catamenial seizures and migraines, treat with a prophylactic or with a higher dose during, before, after, that period, because since so many of us don't respond or have breakthrough symptoms, so I think at some point that's going to happen, but, this kind of conversations really brings it to the forefront. And we've been focusing on women, but that's not to say that men don't have their own issues and men don't have their own hormonal differences. So, it's just that I happen to be a woman, so, I focus on those issues, but I think there are definitely differences in presentation and in and the way the treatment also responds between men and women. And I think that's also part of why we're doing this, because we need to better tailor specifically for the gender, for the men, what their symptoms are and what women's, because it's not one, well, complex, Parkinson's already complex enough. I think it's an umbrella of things. It's not one disease. And then you try to put all men in one lump and all women, it's not, you're not really going to get a lot of, treatment that's going to really focus on the individual. So that's what we're doing this, to try to find those differences. And I always, and whatever, I'm sorry, I'm taking up some time, but when I wrote my book, talked about how with breast cancer, it's not just one type of breast cancer, it's all this type of breast cancer, and how they discover that, looking at the whole, hey, this subgroup looks different. And we discovered they had a genetic abnormality that works completely different. And I think that's what we're trying to do, at least in my part, by looking at women. We're trying to look at, what's the whole, and what is that subtype that we can start peeling out and say, okay, what is different about that subtype that makes it, stand out and work differently, so that we can get some answers for the whole. And I think that that's what always been my point, to try to, look at the differences so that we can then try to find what's the unison, what is the commonality that, that's bringing all of us, with our various Parkinson's, together. So.
You're absolutely right. And we sort of talk about this as, even though we call it Parkinson's disease, it's probably more like a Parkinson's syndrome, with all of these different groups of people who happen to have some things in common, but there's just so much variability, and then, how that impedes research on something works in one group and it doesn't apply to the next, et cetera. I'm curious to hear from Michael. I mean, part of this topic is, as Kat identified, putting it into, is this my Parkinson's or something else, and sort of saying this is Parkinson's, and so therefore I need to talk to my neurologist about it, and just bringing up the issue entirely. The second is comfort with bringing up the issue. And we all know the challenges of the 30-minute, 20-minute, 40-minute, whatever return slot, and all the things that we have to take care of in an appointment. And so oftentimes there's not the time or space to allow for the courage to come up on, let's ask the uncomfortable question. Michael, can you think from your perspective, have there been certain questions or certain symptoms that have been tough to bring up with the neurologist, or that really Parkinson's made difficult to talk about in that visit?
I can, but first of all, I just want to speak to gender differences, and not so much in terms of patients, but in terms of the people who surround you, and having a wide, balanced access to points of view and help. I found that's been true in my case. in terms of the doctor's visits, they're a nightmare. My neurologist and I, we had to have a sit down. I just brought up that 20 minutes was not going to work. The other part of that is I try to be incredibly organized, and my wife helps me with that in terms of notes. I can send emails to my docs ahead of the appointments, and I can attach lengthy Word documents if I need to explain things. So before I go into a meeting, the doctor already has a pretty clear idea of what the issues are and what we're trying to talk about. In terms of subject matter across the board, it's been easy to talk to people about things. What's difficult sometimes is in the short amount of time, I want to know more. I had part of my college degrees were in science, and I want to understand what exactly the mechanisms are that are functioning in my brain. And I know that over the years, that's been difficult for researchers to nail down. But that's the thing that is most frustrating, and I have to be patient with, and I just have to continue reading, and research has to continue on. That's the hardest part for me. I can go to the gym, I can do my exercises. I'm reluctantly starting to take thyroid pills because I needed to, because the flaxseed oil did not work. You know, you make all those small adjustments. It's the unknowns, just trying to, I can deal with whatever Parkinson's throws at me. I just want to know why it's happening. And if I have that knowledge under my belt, somehow that helps me get over the daily humps and the challenges, and I make my adjustments. And then again, being proactive in terms of communicating with my docs is just really essential.
I'll tell you, Shannon, if you don't mind, I'm the opposite. I fear bringing up these topics to my doctor, or I have. The first one was I was having trouble with my urinary tract and the flow. I couldn't keep a stream. It was like I couldn't stand over a toilet and hit the water. Like it's just like I couldn't control anything. I'm like at the time I was like, I'm like 47 years old. This should not be happening. And lots of dribbling. And it's like, oh, I feel like I'm 85 years old. And so I ultimately brought it up. And so now, in addition to a neurologist, I have a urologist. And then I was so ready to bring up the fact that I can't, I have a hard time achieving and maintaining an erection. And I'm too young for that. But it's happening because of Parkinson's. And so after I left my appointment, I emailed my doctor and I said, hey, oh, by the way, I forgot to mention, and he wrote me a script for, some well-known Viagra. And, we deal with things as they come. Oh, that's bad language. Sorry. I didn't mean it that way. Double entendre. Sorry, Kat.
Love it, Lair. Love it. It's all good.
Go ahead, Maria.
Well, just something that Larry mentioned reminded me how my patients always, it seemed like, we spent an hour, and as I'm walking out the door, they go, oh, by the way, doc, I'm having problem. And it's like, we just, and that's like a whole nother conversation. And it's understandable, it's hard to bring up those kind of personal, instances. And sometimes you think you're dealing with things, and not so much, sexual, but a lot of other things. I mean, I just went to my doctor this week, and, it's been my same doctor as a friend of mine, and, I was just there. I think I'm doing well, just, need some medicines. But of course, I go to a university setting. So there's, training students and residents and fellows. And so, of course, they want to learn. And so, of course, I'm like obligated to feel how I'm really doing. Oh, well, lo and behold, I was there just to say I just needed some medicine. I was doing fine. Next thing I know, we're talking about how horrible my sleep is. And the doctor comes in, my friend, she's like, Maria, how long has this been going on? I'm like, oh, years. Don't worry about it. We're doing. And she's like, why didn't I know about it? It's like, I'm managing, and it's kind of like, she's like looking at me like I want to kill you, and it's just sometimes you just kind of, if it's not really broken and you're managing, you sometimes like I said, I had already spent 2 hours there talking to everybody. I really didn't want to like go over, how my sleep has been bad for the last, and so yeah, and sometimes, so Larry, yeah, I understand what it's like, do you really want to talk about it? It's going to be hours before we get to, or maybe there's no solution and you've
Right.
tried all these things and you're like,
Well, I would,
it seems like, and I don't know about you guys, but with me, it seems like, and I was just writing about this, that the longer I've been ill, like the less I want to go to the doctor,
Yeah.
which is terrible. The less I want to talk to anybody or see anybody. It's like, it's like, really, do I really have to? It's like forever. It's like gung ho. Yes, I'm a doctor. We can do this. We can handle it. And now 15 years into it, 20 million doctors, specialists, surgeries, you're like, do I really have to come? It's like, so I can understand. You kind of build a shell, you build kind of a protective thing. You've been through so much. And if you're kind of functioning, it's like, do we really want to make big changes? But sometimes we have to count on our surroundings, and that's why it's important, because sometimes it's like, I think I'm doing along and my husband's like, you're not doing so well, you really need to get that checked out. So sometimes we need that family input to say, that, oh, things are not quite as you think they are. They're not quite as well as, they were a year ago or 2 years ago. So we need to have that back to the communication and the conversation that things are always changing. And unfortunately, not only is this disease progressive, but we age also. And talking about, Kat and the hormones, here I was getting menopausal, and first, I was given a Mentadine and I was sweating like crazy, my God. And of course, everybody's like, oh, you're menopausal, premenopausal. And I'm like, I'm 40 years old. I don't think I am, so I made him get my hormones checked. Everything was fine, but I was like, makeup running, hair all, sticking up. Finally, it took me a while to discover the Mentadine. So went out for that. So then again, a few years later, I'm having all the problems. So then I'm like, okay, I'm menopausal now because I'm getting older, And then everybody was like, no, it's just your medicines. I'm like, oh God, I can't get, like on the track. So finally, after like a year, like, I think I'm getting there. Finally got somebody to check my hormones. They're like, yeah, you're pregnant. I'm like, okay, so now what do we do? So it's that constant being able to differentiate, especially for women. I don't know about men, but when women are premenopausal, menopausal, a lot of the symptoms are just like the non-motor symptoms of Parkinson's. So how do you differentiate? You're having the bladder problems, you're having the foggy brain, you're having the, the sweating, you're having the nightmares, you're having, all those are Parkinson's symptoms. So you have to really kind of, go back and say, okay, let's talk about this. And again, your family, your husband, your spouse, your partner, like, okay, what has changed? Does this happen? Pay attention. Is this related to any medicine changes or any, time I take my medicines, or does this happen all the time at a particular time? And start building a little bit, kind of playing, detective, and then go to your doctor and say, okay, we need to look at it because something, is it my Parkinson's or is it my, and sometimes it's hard to know where to go. You kind of have all these symptoms and like, who do I go? Even for me as a doctor and as a specialist, I'm like, is this my Parkinson's or is this my migraine? Or is this my, hormones? And so you're like, okay, who do I call first? And so you have to have somebody that, okay, you can count on and trust and say, okay, you're going to be the lead person, that you're going to take care, and then we can go, and so it's just that communication and that constant juggling and constant reinventing yourself and learning that things are always changing, and you have to be able to change in order to move forward.
what I'm hearing from a lot of you too is that effort that goes into trying to figure that out on, is this Parkinson's? Is this something else? Is this something my neurologist should bring up with me or that I should bring up with my neurologist? Michael, I love your recommendation for sending a note ahead of time. I think one of the nice things about writing it down is that it's easier to write down those uncomfortable topics or those uncomfortable questions instead of feeling like you need to bring it up in the flow of natural conversation. Kat, I kind of wanted to ask you a question with regards to a paper that just came out in Movement Disorders. Our Movement Disorders journal The paper is titled Unmet Needs of Women Living with Parkinson's Disease, Gaps and Controversies. And one of the quotes that really struck me was that women report less sexual dysfunction than men, but this may be due to an underreporting by women who may be less likely to talk about these sensitive issues or not being asked by their mainly male providers. And so perhaps for my females on the panel and for my males on the panel, do your providers ask you about sex and intimacy? And by contrast, do you bring this up with your neurologist in your kind of routine follow-ups?
So I have never been asked about sexual function at any appointments. I spent a lot of time talking about reproductive health with my patients. And in every annual exam, I talked about sexual function, and in the hopes to start giving women permission to start talking about sexual health. Like I said earlier, we're not just in boxes. Excuse me, our sexual health is an integral part of our health. And I know for me, a diagnosis of anxiety and depression predated my diagnosis of Parkinson's disease. And in retrospect, probably was Parkinson's. And I know that we treat anxiety and depression often with medicines that can really impact our ability to achieve orgasm. And I think that women, sexual health is not talked about enough. And I think because women's orgasms are a little less overt than a male orgasm, that we don't realize that it's part of the joy that we can have in our lives. And it may take more work, it may take more awareness, it may take some uncomfortable discussions, not just in an exam room, but even in a partnership with your partner. I've been married for almost 32 years and to the same man. And thank you. I know that feels like a big one. And but I think Michael's got more time on me. But anyway, but we talk about it. But even talking about it all at my work didn't make me automatically comfortable talking about it. And Larry and I and our partners are getting increasingly more comfortable talking about it, because I think we've got to bring it up. We've got to encourage our Parkinson's friends and allies to be talking about it, to be thinking about it, to know it's really common, both with treatments, and if we're not talking about it, we can't get help with it. And also to encourage our colleagues, our movement disorder specialists, our primary care physicians, our urologists, all the ologists, nurse midwives, nurse practitioners. Can we include this in our assessment? We learn it in our training. It's part of your exam. It should be. So let's start remembering that that's a part of who we are, and that's, it's part of our joy. And it may change. It has certainly changed in our lives in the 32 years. It takes intention, it takes conversation, it takes flexibility, both in mind and in body sometimes. But it's important, and it's our bodies. And if we don't talk about it, we can't get help with it if we need it. Larry, kudos to you for bringing it up. I've been bringing it up more with my movement disorder specialist, more as in my advocacy role. Can we have these dialogues? And is this medicine? There are other medicines we can use to treat anxiety and depression, right, Maria? There's other tools. So there's toys that can help. There's a whole marketing world out there that I didn't even know about until more discussions, right? So
is your neurologist or your movement disorder specialist open to these conversations?
She is, and we know each other. pretty well. She and I are able to have, partly because of my history as a clinician and partly because she knows I'm doing a lot of advocacy work. And I get Botox with her. So I have long appointments where she's poking me with needles, and somehow talking about sex is a good distraction when I'm getting poked with needles. But I have her attention for a while, and we can have some of those dialogues. So anyway, get out there and talk to your providers if you're not enjoying sex.
And the conversation with your partner is really important because, you know, intercourse isn't the only love language you have. And so if that becomes an obstacle, then there's intimate conversations, there's, you know, activities you can do, you can snuggle, I mean, there's all sorts of ways that you can express yourself and be intimate. And we've had to adapt to that. And I think, you know, some of it is just making sure that your space, where whatever space that is, we don't share, you know, we have shared space with our bedroom, but I don't sleep in our bedroom anymore because of night terrors, and I act out my dreams at night and thrash about. And so, you know, we're not, that used to be where we go at night, we'd have our little conversations. Now we have to have them. Went on a walk the other night and just sort of told our son, like, no, you've got to stay home. This is our time. And so we're changing the way we go about it. And I think that's really important. I do get asked about my sexual health on a sheet of paper before I see my neurologist, but I think they throw them in the trash because I've never had a follow-up.
A great point, Larry. Great point.
I think one of the things that's important is that you keep searching. I brought up the subject with my neurologist, and surprisingly, he was more open to my exploring acupuncture than dealing exactly with the questions that I had. And then later on, I became aware of a research model and some work being done at Stanford University. I haven't gotten the time to research that yet, but you have to know that if you keep searching, there's answers out there. It's important not to give up. And second, I second the comments have been made about communication. That changes over time. You know, your relationship evolves and develops, and the communication is the glue that helps you make adjustments and hold everything together.
Such wonderful points, and that's absolutely right, especially as we age, as you know, with or without Parkinson's, things that are happening with our bodies become a little less sexy over time. And you know, was brought up in the chat, a lot of gastrointestinal issues, urinary issues, sexual issues, just the cosmetics of having Parkinson's, the motor issues and the facial expression, just trying to find new ways to communicate with others and show that affection in verbal and nonverbal ways. Larry's given everyone the eyes right now if you're not feeling it in this particular session. Michael, you bring up research, and it's kind of been touched on a few times in our conversation, the paucity of research on these topics in general. Maria brought up that, you know, there is a story to estrogen and Parkinson's, but we're not totally sure what that story is. There's a story about maybe the subtypes and how men and women may contribute to those subtypes. So the question I want to ask each of you is, if you could have one question that science could answer along gender or sex implications in Parkinson's disease, what's that one research question that you think needs to be tackled? And as you're thinking on your answer for that, I would love if folks in the chat also could maybe offer up their questions. What's the thing that you'd like the Parkinson's research community to look into and answer with regards to gender and sex in Parkinson's disease? So maybe Maria, I'll start with you.
Oh, sheesh. Of course, there's a lot of questions,
A
but
million questions. That's
think
the hardest
I
part,
know.
is the one.
I think the one thing that I always struggle with, besides, you know, is there a hormone difference? Is there a timing with hormones? Timing is the issue. When hormones stop playing a role or increase the risk or decrease the risk. And if so, like, when is the time that you take action? You know, like, when do you replace? Do you replace, you know, post, menopause, like, doesn't matter. Do you replace? So that's my big thing. I think there's a hormone issue. I think that definitely, we see it with other illnesses, but just like with strokes and with Alzheimer's and with heart, there's a timing where, replacement and increasing and improving the hormones makes no difference and actually causes deleterious effect. So is that the case with Parkinson's? And I think that if we can figure that out, we're making a huge, understanding of what or how, gender differences really occur or affect us.
Absolutely. And in thinking through hormone replacement and our folks who are transitioning or taking hormone supplements, I mean, that has huge implications.
Yes.
We know that's true in the cardiovascular world. It makes sense that that would apply in the neurologic world as well. Thank you for that. I love that question. Larry, what question would you ask?
Well, I've interviewed quite a few women on the podcast about their experience with Parkinson's. And one of the things that's really interesting is there's been several women who share their experience of pregnancy and giving birth. And during birth and shortly thereafter, they don't need any levodopa because their natural hormones kick in and take over. And I'm wondering if we just all need a big shot of estrogen or something. So would that help me? If so what is in that magic mix of glorious chemicals that happen during childbirth that may be a secret to us, helping to solve this issue?
Absolutely. I love that question. I know from personal experience, you become a superhero after you give birth. And so it stands to reason that there is some sort of secret sauce that we could tap into. Michael, what question would you ask the research community?
I know there's a connection between emotions and my motor symptoms. And I can look perfectly normal. And then suddenly if I lay down, I can have to deal with some shaking issues. And again, I just want to know the mechanics of that, what's going on in terms of my body, and then work on ways to kind of deal with that. Parkinson's is one part of a Gestalt world that I live in. When I got my thyroid resolved, at first I thought it was Parkinson's, but it wasn't Parkinson's at all. It's just being able to sort all this. If research could help sort all these things out and focus with definite solutions, that would be great. When I first got diagnosed, I couldn't walk right. I spent a month with a physical therapist. Now I can swing my arms and I can walk right. And I just, one little thing, if we could find the fix and make it work, that's what would help. But just basic brain science would help me.
I agree. I mean, the study of neurology used to be, physicians used to be neurology and psychiatry board certified, and now those two are sort of finding their own silos, which is the case in medicine. But I mean, that mood implication and how that relates to your motor symptoms is such a critical piece to this puzzle. How, the dopamine and anxiety and depression, how we respond to pain and what impact that has on all of these symptoms. And it does sort of feel like we are maybe throwing treatments at it to see what sticks and not necessarily with that really prescribed, like you said, that when my walking is a certain way, I have a program that I go on with my physical therapist, or if I'm speaking is a little softer, I do Lee Silverman voice therapy. I know that that is the thing to help with this. And with the non-motor and the mood symptoms specifically, it's not so well defined. So I couldn't agree with you more on that. Kat, what research question would you ask?
Yeah, it's hard to go last. I'm just going to say that I think they are all really good questions that I've heard, and I would piggyback that. I think that I like the direction that medicine's going, looking at the individual and trying to tailor treatments for lots of things that are specific. I'd like to see us become a little bit more creative with perhaps, are there treatments that are better suited to women versus men, or women with a uterus and ovaries versus, you know, a biological man with testosterone? Are there differences, and are we missing an opportunity to maybe tailor treatment by not looking at that more specifically? So my question would be, are there some tools that we can be using that are being missed that might help tailor our individual treatment?
I know that you have spoken to some mechanisms to help us gather that data a little bit more. I'm putting you on the spot, a database perhaps to help. Do you want to maybe speak to that idea? Because I love this idea.
So, well, I think that there are lots of people doing some great work around the world, and I think that there's some woman overseas that's looking at collecting a database for women that are pregnant with Parkinson's. And so I think that data is going to drive where we go with things. And so I think we're sort of on the cusp of recognizing that. And the world's getting smaller with all our Zoom calls and all of us collaborating on Zoom. So I think it's going to take some worldwide data management to because there's such a small percentage of people that experience pregnancy with Parkinson's. And so we're going to have to move the research agenda with data. So if you're out there and you're interested in getting involved, there's lots of avenues to do that. APDA, PD Avengers, WPC, Women's Parkinson's Project. I mean, we're all out here trying to have the dialogue. So get involved, learn information, and help us change what we ask for from our research teams.
And Ken, I would just say anybody who has Parkinson's should be keeping a journal because that's how you're going to track your symptoms. That's how it'll help you right before you have to go to the doctor. What's giving you the most? What's interrupting your day the most? It'll help you have conversations with your wife, with your child. It just gives you more perspective because I have so many symptoms in a week. I couldn't remember them all if I had to. And so I think it's really helpful for me. Just, I can't even remember what I had for breakfast today, let alone what I felt like 2 days ago.
Right.
So it's, I think it's really helpful. And then that becomes your data.
Yes. And you're your own best expert on your disease, and whatever that is, whatever, you're your own best expert about everything, not just your disease, about your health, about your wellness, about your joy, about your story, about and Parkinson's is just a part of that. But I agree with you, Larry. Documentation is really helpful. Yeah.
Well, we're coming towards the end of our hour, but I wanted to give our panelists the opportunity. Are there any final thoughts or words of wisdom that you have to share with our group here? Larry, go for it.
Okay, so my first date with my wife was in New York City. It was about 10 o'clock at night. I had driven 14 hours. We went to an Indian restaurant, had a great meal, and then we were intimate. I can never imagine doing that again because I'm old and I have Parkinson's, and boy, I can't imagine having Indian food before having intercourse. That just doesn't sound appetizing at all anymore. So just understand what we used to be able to do, we can't do anymore. So you have to be creative and you have to be open to new ways of living and loving and being intimate with your partner.
I love that.
I'll go. I find a little joy in every day. And I think you can do that. I think if you train your brain to be looking for the good things, whether it's a loving moment with your child, whether it's taking a walk outside, or just being grateful for the garbage pickup, it's find a little moment of joy. It's Wednesday. That's when my garbage gets picked up. I'm grateful every Wednesday.
I think it's been really hard these last 2 years and isolating for a lot of people. And I've had to go out of my way to make connections. But my little bit of advice would be connect with other people and be kind.
Well, I think that my final thing would be that you have to keep being yourself, have to have goals, short-term, long-terms, and not just goals personally, but goals within, your family, your relation with your spouse, things that you want to do, your partner, and other, have still a dream, still have something that you can do and want to do. Of course, may take twice as long, 10 times as long to do, or have to reinvent it to do it. But, just to know that you can do this. But intimacy, as everybody's been talking about, is not just the sexual intercourse, but finding ways to spend time together, touch, cuddle. Sometimes you just, as we get older, you may not be in the mood for all those things that have nothing to do with Parkinson's. Your spouse, your partner may also be going through things. So, find ways just to bathe together, or to, give a massage, or, just ways to connect, because sometimes the deepest connection is not even physical. It's more, finding that communication. Like Larry said, my husband is a morning person. I become a totally night owl with my Parkinson's. We communicate somewhere in the daytime in between. And sometimes, I'm going and he's going, and it's like, when we haven't seen each other. So, it's like, find that time wherever it works, that, hey, wait, you gotta give me 10 minutes right now. Let's catch up. And, and sometimes just hold hand, cuddle, and then talk about whatever, children, family, whatever's going on. And that connection, that intimacy is what really drives it, whether, and then of course being creative, oh, God knows we've all got all kinds of stories of creativity, so, and being open to it. And I say, well, I can't do that anymore. That's it. Our life is over. You have to say, okay, well, let's find another way to do things, whether it's, bathing, washing dishes, having intercourse, whatever, just doing things. And that kind of puts a fun thing in it, like rediscovering things,
And you could laugh a
relearning
lot.
and reinventing
It's
yourself.
funny.
Yeah.
What we're going through is funny.
It is. Sometimes it's just like, oh my God, did we do that? Oh my God, is that going to work out? So then you just kind of got lots of stories, and you just shake your head and you laugh, and, one more story to share, so that's all I would, I would say. And just like you said, journaling, I think journaling is important. Whether it's, scribbling, whether it's a video journal, whether it's writing journaling, whatever works for you. I think that helps you, one, to get your thoughts out and to feel that, process things, but also it's something that can help you look at, oh, my mood is worsened, or my, my handwriting, so you can have a visual effect of what's really going on. That's more, objective than just kind of feeling, I think I'm not feeling as well as I did a week ago, but you have something there. So.
Well, I certainly can't improve upon any of these wise words of finding that joy, finding that connection, being flexible, finding the humor, and the satisfaction in the creativity. I mean, these are amazing points that you've got. So I want to thank each of you for being so open and vulnerable and sharing your experiences and your expertise. And as I said, I hope our goal here is that we know that this is just scratching the surface. I mean, barely even scratching the surface of this conversation. And so hopefully our goal of maybe raising a few issues, getting folks to think about some things that maybe they hadn't thought about, that maybe the APDA can have us continue this conversation in a more formal setting, or certainly would welcome you all to bring it back to your communities, to your doctor's offices, to your support groups, to your online forums, to wherever you go, your own networks, and keep these conversations going. We aren't able to tackle these wonderful research questions that we brought up if we don't speak up and bring it up and make some noise along those lines. So